Not able to hear you. I'm just going to unmute. Morning. Morning.
Good morning. I just want to select.
I'm not able to hear you, Prof. Barbara. Can you hear me, Prof? But I can't hear you. I might just. I'm just trying to I can't hear you, so I might just 1 minute. No, I can't hear you.
Should we start now, Rahul?
Yeah, we can start, and Barbara can share her slides now.
Okay, all right. Okay, we tested all that before, so that's good.
So you want me to share my screen?
Yeah, sure, you can share.
Yeah. So to introduce Barbara, I knew Barbara for quite a long while when I was in Canada, and I even been to. Can you hear me?
Yeah, I have a problem now with my.
So let me just continue introducing Barbara. She is well known for her evidence-based practice medicine, and particularly when have sometimes had a work at Hamilton, my master university, the ground of EBM, evidence-based medicine. So, and I have the fortune to be to home in some stage in Hamilton together with Harish, my old friend. And it's very fortunate for us to, the slides are up, that's good. So I think one of the things that she had produced, particularly most recognized in the world, is caffeine, the use of caffeine. And so we have done a lot of, we know that Barbara has done a lot of work, randomized control trial. And I think sometimes when we have evidence, we say, well, what are the variations? How do we apply it? Is it always the gold standard? We do believe so. So where are the limitation and how do we do it? And we, without any more further, we go and we hand over to Barbara to start this talk. Thank you, Barbara.
Thank you, Key, and good morning, everybody. And I also want to thank Julie once again for inviting me back to this successful Sydney webinar series. This morning, I will discuss evidence-based variation of clinical practice in an era of prescriptive guidelines. I have no financial relationships to disclose, but I will use caffeine and also oxygen therapy for very preterm infants as clinical examples in this talk. And therefore, I should mention that I was the principal investigator of both the CAP and COT trials, and also a contributor to the neonatal oxygenation prospective meta-analysis, or Neoprom. Can you all hear me clearly if I speak like this?
Yes, we do.
Okay,
Yes.
thank you. So it is often said that clinical practice variation is undesirable and must be reduced. And guidelines are designed to make our practice more uniform. But is variation in practice always bad? Are there good reasons for variation? And can the number needed to treat, or NNT, help identify whole neonatal ICUs where treatment should vary? These will be my central questions for our discussion this morning. I'm having some difficulty advancing the slides. Let's briefly refresh our memories about the NNT, or number needed to treat. The NNT is an absolute measure of a treatment effect. I think it's become popular because it is intuitive and also easy to calculate as the reciprocal of the risk difference, which in the case of a treatment benefit over the control group is also called absolute risk reduction. Of course, if it turns out that the treatment is more harmful than the control, then this risk difference becomes an absolute risk increase, and we begin to talk about not numbers needed to treat, but numbers needed to harm. The NNT was added to our toolbox over 30 years ago. Andreas Laupakis, the late David Sackett, and Robin Roberts published their seminal paper on clinically useful measures of the consequences of treatment in 1988 in the New England Journal of Medicine. All three authors were affiliated with McMaster University in Canada, which was a pioneer in evidence-based medicine at that time. And as a graduate student at McMaster in clinical epidemiology in the 1980s, I was very fortunate to count all three authors among my teachers and friends. Here is the example that was provided in that original 1988 paper on how to compute, how to calculate the number needed to treat. The example that was used was from a 1970s trial on hypertension, treatment of hypertension done by the Veterans Administration group. And the young people will be astonished to hear that it was only about 50 years ago that we were doing, or the adult physicians were doing, placebo-controlled trials of hypertension. So this was one of the earliest trials of hypertension, and you see here a group of patients that are pretty sick from their hypertension already. They have target organ damage, and the adverse event rate that they were concerned about had a rate of 0.222 or 22.2% in the placebo group, and by the treatment of hypertension, this was reduced to 0.085 or 8.5%. So the risk difference, or what is in this case because of treatment benefit and absolute risk reduction, is simply 0.085 subtracted from 0.222, and that is 0.137 or 13.7%. And remember, the NNT is simply the reciprocal of this risk difference. So 1 divided by 0.137, which is 7.3. We cannot treat our patients in decimals. So we have to round these numbers. There has been an astonishing amount of debate over the years as to whether it should always be rounded up, regardless of the decimal. But the people who gave us the NNT, as you can see, rounded 7.3 to 7. So very simple measure to compute. All you need is basically pen and pencil and paper. But here is one of the catches. Already in the original publication, there was this table 2, in which the authors drew attention to the fact that the baseline risk of your patients for the outcome of interest has a big impact potentially on the actual number needed to treat in your own patient population. You can see in this table, which is far too complex to sort of digest in its entirety today, but you see this red framed very first column gives a wide range of baseline risks. These are for whatever outcome you might be interested in based on the trial that you're reviewing or the systematic review meta-analysis. And you can see that the baseline risk ranges from a very high 0.9 or 90% to all the way down to 0.1%. Now, let's just look at one simple example to understand how the NNT changes, sometimes dramatically, with changes in baseline risk. So we simply now look at the treatment that has a 50% relative risk reduction. This is huge. Very few treatments in medicine are this powerful, but let's just play with this. So 50% relative risk reduction means that the bad outcome that you're trying to prevent is reduced by half. So if your patient has a 90% risk for this particular outcome, for a treatment that has a 50% relative risk reduction, the point estimate of the number needed to treat is only 2. That very same treatment, however, will have, for example, an NNT of 40 if your patient or your group of patients has a much, much lower risk, in this case where I gave you this example here, of only 5%. And these are just the point estimates of the NNT. We haven't even begun to talk about the confidence intervals that, of course, are always around a particular point estimate and have to be factored into our treatment considerations and treatment choices. So I want to stress that, you know, even in 1988, when this measure was first introduced, there was already a big red flag that you can't just simply take the number needed to treat from a trial that you're interested in and want to apply to your patients. You have to first check that the risks of your local patients are similar, and if they're not, you have to recompute the NNT. So I hope I have already made it clear that the baseline risk is a consideration that is of huge importance, of course, in all branches of medicine, but also, of course, in neonatology. Except I think we can begin by focusing on baseline risks of our respective neonatal ICUs, rather than the individual patients within them. We all know that we have big differences with respect to outcomes for mortality, for example, for very preterm infants, but also for important morbidities such as bronchopulmonary dysplasia, between different neonatal ICUs, between different hospitals, sometimes even within the same city. And so I think for the rest of this talk, when we discuss baseline risk, don't get hung up on an individual patient, because we're working in these systems but think of it rather as the typical baseline risk that you would know from your audit and from your benchmarking for these important outcomes that are unit specific and of course change over time. So Bronchopulmonary dysplasia is obviously one of those morbidities for which we all know our local unit rates. We also know that there are 3 different drugs that have been shown in randomized trials and systematic reviews of those trials to reduce the risk of bronchopulmonary dysplasia if they are given early, so essentially in a prophylactic mode. And these drugs are caffeine, vitamin A, and hydrocortisone. I want to show you in the next couple of slides, by just touching on this discussion, how the baseline risk of your local baseline risk for bronchopulmonary dysplasia may have an impact, may determine the choices of treatments that you make, whether you choose to, for example, introduce vitamin A or hydrocortisone into your unit as a measure to reduce the risk of BPD. And we published this particular comparison just recently to help people think about also how to compare the size of a treatment effect, in this case, in the same population for the same outcome, and also the certainty of that treatment effect. So let's begin with caffeine. We know from the CAP trial, which showed that caffeine does reduce the risk of BPD at 36 weeks post-menstrual age. And in the original trial, the control group event rate, the placebo rate was basically 47%, so almost 50%. And with the treatment effect that we observed in the CAP trial, the NNT was 10 and the 95% confidence intervals were fairly tight at 7 and 16. But you may not have a almost 50% BPD rate before you're using caffeine. If your risk is lower, your number needed to treat will rise. If your risk should be higher than that, the number needed to treat will fall. So let's just look at a very ideal situation where your BPD rate would be only 20%. And then based on the caffeine effect we observed in CAP, it would come down to 15.5% on average with caffeine. You now would need to treat on average 22, not 10 patients, but you would still see that the confidence intervals remain quite tight. Obviously, they get a little wider, and but at most you would be treating 37 patients on average to prevent 1 case of BPD. The situation, and I'm skipping the vitamin A because my sense is that it's not a treatment that is used widely in Australia, unless I'm mistaken, the IM injections of vitamin A. But let's look at hydrocortisone in comparison. The case, I think, is quite a bit different. Also keep in mind this sort of graphical display of the width of the confidence intervals for the NNT of caffeine, and now compare it to hydrocortisone. And the data for this analysis are taken from the individual participant data meta-analysis of various trials of hydrocortisone that was published about a couple of years ago. So I think the first impression you get, and particularly if you compare it side by side, which we have done in the original paper, is that the treatment effect for hydrocortisone with respect to the NNT is far less certain. So let's assume again, you have this ideal neonatal ICU where these very immature babies only have a BPD rate of 20% before you consider using hydrocortisone prophylactically. The number needed to treat is still reasonably low. It's higher than for caffeine, but 31 is not too bad. But look at the upper limit of the confidence interval. It's a whopping 861. I think it follows that a unit where the BPD rate is quite low compared to elsewhere should really think twice before deciding to make this a unit policy to add hydrocortisone to their armamentarium, because you could end up treating nearly 1,000, no, well over 800 babies before you prevent with hydrocortisone, which is, you know, a quite powerful drug, before you prevent one case of BPD. In this particular case, where we published these comparisons of NNT and the 95% confidence intervals for these 3 drugs to prevent BPD, you just look it up and can therefore then come up with credible NNTs for your own situation, your typical unit risk for this particular outcome. But these publications are exceedingly rare, and even the actual trial reports or the meta-analyses of trials certainly don't provide this information. So you have to compute to really meaningfully apply a result from a trial that is rigorous and of a treatment that looks promising. But before you figure out how this would work in your own unit, you really then need to see how the baseline risks compare and how to recompute it for your local situation. This is a bit tricky for most clinicians. I would count myself among them, and we don't walk around our neonatal ICUs with a statistician in tow. But thankfully, there is a really easy shortcut to this estimation of both the NNT and the 95% confidence interval for this NNT, because your local risk is simply the factor F times the control group risk in the RCT, whose result you want to apply potentially in your own unit. And you simply then divide the study NNT by that factor, and you do the same for the confidence limits. So a very easy to follow example, and I made it especially easy so we don't even need to use our handheld calculators. So you have a baseline risk in the RCT, that is always the control group rate, of course, of say 50%, and the NNT is 10. And the 95% confidence intervals are 7 to 16. In fact, this is basically the caffeine effect on BPD, just I made the rate 50 instead of 47 for ease of calculation. But your local baseline risk is only 25%, say, again, picked for easy calculation. So the factor F, by which that I mentioned up here, your local risk factor is factor F times the control group risk. So if we have 50% in the trial, but your local risk is only 25%, that factor F, of course, is 0.5. So you then divide the study NNT of n by 0.5, and this gives you your local NNT of approximately 20, and you do exactly the same thing with the 95% confidence intervals, divide by 0.5, and they come out as 14 and 32, which is very close to the numbers you saw in the publication for caffeine. So a very easy shortcut that anyone can use without much mathematics. My next example will be oxygen saturation targeting in very immature babies. And I want you to imagine for a moment that you're a neonatal clinician who moved recently from NICU A to NICU B. And as one does when one moves, you study the practices in NICU B and you also compare them to NICU A. And you start with the local policy on oxygen therapy for preterm infants because NICU B has a lot of takes care of a lot of very preterm babies, extremely preterm babies. With respect to oxygen saturation targeting, there have been recently many guidelines published, national, international, or local hospital guidelines. I could not actually find one that covered all of Australia. Maybe I just did a very quick and dirty search, so maybe I wasn't thorough enough. But there is, just as a fill-in, the guideline from NICE, the National Institute for Health and Care Excellence in the United Kingdom. And you can see that, like other guidelines on the same topic, it states unequivocally, after initial stabilization, aim for an oxygen saturation of 91 to 95% in preterm babies. Where do these guidelines come from? Well, we all obviously know the evidence base for these guidelines. Recent guidelines on oxygen saturation targeting come from the prospective individual participant data meta-analysis of 5 randomized trials of oxygen saturation targeting in extremely preterm babies. The Neoprom collaboration, obvious, and in fact, this particular initiative was led by Lisa Askey out of your city, Sydney. So this slide summarizes the main results from Neoprom, which I'm sure everybody who's listening in is familiar with, so I'll be very brief. We have on the left, in the left-hand column, the outcomes of interest, followed by the 2 target ranges, basically the high 80s versus the low 90s. And in the right-hand column, the risk difference with 95% confidence intervals, but only for those outcomes where there was a significant difference. So despite randomizing nearly 5,000 extremely preterm infants, there was no significant difference, as we all know, for the primary outcome of death or disability at 18 to 24 months corrected for prematurity. But among the secondary outcomes, there were significant differences for these 3 outcomes: death, severe NEC, and treated ROP. By targeting the higher range, the risks of death and severe necrotizing enterocolitis were reduced, and you see that here. But that came at the price of increasing the risk of treated ROP. You can see I didn't put p-values into this table, but the fact that these 95% confidence intervals around the risk differences do not include one makes it obvious that these are significant differences. I do believe that all 3 outcomes are undesirable, although I've heard it said many times over the last few years that death trumps all. I hope to convince you, however, to at least think about the possibility of considering a trade-off in situations where a local neonatal ICU has very low rates of mortality and severe necrotizing enterocolitis, but high risks of retinopathy of prematurity. Jules Bastien Lepage painted a blind child, and you will immediately and rightly argue that blindness from RP can most, if not always, been prevented by diligent ROP screening and appropriate therapy. And indeed, at 18 to 24 months, there were no significant differences for blindness in Neoprom. But we tend to forget that blindness is not the only adverse consequence of severe retinopathy. Firstly, there are long-term serious visual disabilities other than blindness that tend to show up only as the child gets older and into childhood and school age. But at least as importantly, there are also very strong associations between treated ROP, severe ROP, and non-visual disabilities later in childhood. And we showed this in over 1,500 children who participated in the CAP trial at age 5 years. At that age, motor impairment, cognitive impairment, and severe hearing loss were each 3 to 4 times more common in children with than without severe retinopathy. And that is despite the fact that, as in Neoprom, children were seeing, they were not legally blind, yet we had these very strong links between non-visual disabilities and treated ROP. So I think let's be clear, even in high-income countries, and the CAP trial is only done in those types of countries, even in high-income countries with adequate ROP services for screening and treatment, treated ROP, severe ROP, remains a debilitating consequence of neonatal intensive care. At this point, I want to insert this quote by Kent and Haight, who wrote a very good article in JAMA in 2007, the references at the bottom, about essentially how to apply the results of trials to your local patients. And the quote is printed here in big letters. When a therapy is associated with even a small amount of treatment-related harm, low-risk patients are unlikely to benefit at all. I like to say, because I like to show this quote, I like to say, especially the young people, the trainees among us, should maybe consider making this quote a screensaver on their gadgets to never forget it. So let's go back to our 2 neonatal ICUs and compare their rates for mortality and treated ROP. NICU A has a mortality rate with lower targeting, and this is, allowing the high 80s. Not exclusively, although that was the goal in the Neoprom trials, but I don't actually know anybody who exclusively targets the high 80s. We can discuss that more after the formal presentation. So with lower saturation levels, the mortality rate was 20% and the treated ROP 11%. Not coincidentally, these are exactly the Neoprom rates for these 2 outcomes in the lower target group. In NICU B, the rates are different, and you can see I simply flipped them. So now the mortality is down to 11%, and the treated ROP rate is up to 20%. Although I made these rates up, they are completely credible, and I will show you and plausible, and I will show you in the next couple of slides why I'm confidently saying that. You're probably all familiar with these publications from the International Network for Evaluating Outcomes of Neonates, and they basically combine the data from 10 national networks, and I see Key's name in there, and your network is obviously Australians, I'm in there, and the New Zealanders. So this is very valuable information, and you can see here fairly recent data for survival in this group of patients, 24 to 29 weeks gestation, mortality rates ranging between the networks from 7 to 22%. So my 11% for NICU B is really not the lowest I could have picked to make my point. The same goes for treated ROP. If anything, the variability is even greater, and this was published by your neighbor, Brian Darlow, ranging all the way from 4 to 30% between those networks. So the example of 20% for NICU B, again, even though it seems high, is not as high as I could have made it and still stayed within this range. Let's look at the benefits and risks of higher targeting for NICU A. That is the unit with the Neoprom outcome rates for mortality and treated ROP. So with these Neoprom rates, the NNT for mortality is 36, and the number and the confidence interval is 20 to 167. Treated ROP, of course, is increased with higher targeting, so the number needed to harm is 25. So on average, you need to treat 25 children with higher saturations before you create one extra case of treated ROP, and the confidence intervals are quite tight, actually 16 to 50. So you can see that even NICU A, which has the Neoprom rates, is clinicians there are more likely to create an extra case of treated ROP than save a life. But I think the consensus over the last few years has shown that most people would still agree that mortality is, in this case, outweighs treated ROP. What about NICU-B? So we now have a lower rate of mortality, 11%, remember, and the NNT therefore will rise. The point estimate is rising to 53. The confidence interval all the way up to 227. Treated ROP is higher, however, at 20%. So this means the number needed to harm will drop from an average of 19 with tight confidence intervals as low as 14 and no higher than 36. How you trade off these types of numbers has no longer anything to do with science. The scientific part is recognizing that you cannot simply take the Neoprom numbers and apply them locally unless you have very similar outcome rates. And we have to remember that mortality was actually high in Neoprom at 20% in the lower target range. What I should perhaps add in parentheses is that between the 5 trials, this mortality rate in the lower saturation group ranged from 15% as the lowest to 25% in the highest. So this between trial difference was 10%, which is actually more than 3 times the difference that Neoprom showed targeting higher makes on mortality. So how these numbers, depending on the local balance of baseline risks, are traded off against each other has now not anything any longer to do with science. These are value judgments, and I'm not going to tell people how these decisions should be made. All I want to do is say, when does this trade-off become questionable? We should at least think about it. And when should it be discussed with parents? You are in a unit with very low mortality rates, but struggle with your ROP rate. But you decide to never allow the sets to drop into the 80s. You want to be always in the 90s. Perhaps this is something that should be discussed with parents till they really understand the implications. So the summary of what I've just tried to present to you is now back from the values and clearly scientific, because those facts cannot be disputed. The example I gave you, NICU-A, has a fairly high rate of mortality and a lower rate, not really low, but lower rate of treated ROP, whereas NICU-B has a fairly low rate of mortality, but a high rate of treated ROP. So it follows, and this is not a value judgment, this is scientific fact. It follows that NICU-A and its preterm patients will gain more from targeting higher saturations than the patients in NICU-B. So to come back to the questions I posed in the beginning, is variation in clinical practice always bad? No, I think I'm actually getting concerned when units with wide variations between them in the baseline risks for the outcomes to which they apply treatments are all doing the same. Are there good reasons for variation? I think I will answer that, as you've heard, with a resounding yes. And can the NNT help identify neonatal ICUs where treatment should vary? Again, I hope I have shown you a little bit how that can happen. And with that, I want to thank you for listening, and I look forward to your questions.
Thank you, Barbara. That's fantastic background. I think it's important for us to realize there's a lot of variation. In fact, thank you for quoting the 2 publications that I was involved in. In fact, I did all the some of the slide illustration for Brian Darlow, how they varies. The other thing is also, I think it's important that we realize, even when we talk about each network, as you have showed that the 10 network that we belong to, there's a lot of variation within the network. Also the change in time, how they improve. I think we have, for recently, the 2019 and 2021 publication that I've been the first author, to show that there are a lot of variation. The way we improve, we all different. Some improve in one way and then lag behind the other. So that's quite interesting to actually exactly what you've been talking about. You need to look at your own data to decide on what to how to improve. Now, are there any questions that come from the audience? Anyone like to raise questions? Yeah. I think I really enjoy your talk. I think it really rhymes with me with quite a lot of the thoughts I have, how the network should improve collaboratively, and which each one to look at their own background to decide on what to do. So that we do a lot of benchmarking, we provide a lot of data back to the unit so you can see which area they are getting better, which area they are still dragging behind. Those doesn't seem to, that is very interesting. I thought it was a bit, any other questions that we come from? Julie, you got any questions you want to?
Oh my God, you're putting me on the spot, aren't you?
Yeah, that's right.
Great, thank you, Barbara. It's a very, very, I've taken, Nadia says, thank you very much for a thought-provoking talk. I think the most important thing is to take our unit, baseline numbers into account before we apply blindly what all the RCTs tell us to do, which can be quite difficult when you're in the front line face of a dying child, I guess. Is there any thought about that, Barbara?
Well, back to what I always like to tell trainees, the more desperate the situation, in other words, what you describe as it can't be much more desperate, a dying child, unless there is a decision not to do active management. But the more desperate the situation, the more anecdotal you can actually become. The healthier the patient, the more the patient has to lose, the more rigorous I think we have to be in applying evidence, because the first goal is not to harm. Right. I mean, in front of a dying child for whose problem there is no clear evidence, we can't run away to try and find the right Cochrane review, right? It becomes it's a little bit how delivery room resuscitation happened. And to their credit, I mean, the folks in Melbourne and also elsewhere in the world have put a lot of grounding, and you actually, Julie, under those situations, and we are getting better, but that doesn't happen overnight.
And I see Jackie Stack on the line. There was a very good study from Liverpool in Sydney. I think it was led by Robert Goran a couple of years ago with a medical student where she asked the parents to recall what they were counseled about by the medical and nursing team about the risk for their babies. And many of the parents couldn't remember much. And one parent said, all I could remember was that the neonatologist was wearing a red dress.
Yeah, I believe that. I mean, and those studies have been done. Absolutely. In fact, he may remember Nitsa Perlman, Max Perlman's wife, who was a psychologist, did one of those studies back in the 80s, and she actually videotaped or at least taped it, and I don't know about video, but, and she actually also compared what the physicians recalled from what they thought they had told the parents, and then what the parents said they recalled, and the discrepancies were just extraordinary, actually.
Yeah, I think the other one is Quan Ko, who have done quite a lot of work and who is to read it, is to tape and give it to parents to listen to at any time. And they published a number of times on that. I think the difficulty is sitting on your hands sometimes. Sometimes with a very big tendency that we do things and we're thinking that is applied for. So there's particularly extrapolating those studies coming from the more moderate severe diseases and apply to the mild diseases. I think that is fundamentally flawed because that is not what you should have a vigorous trial. But in fact, you can use those, like exactly what Barbara you have done, is you can still able to extrapolate some of the data applying to the the lower degree of diseases, but you adjust the baseline risk. I think that will be actually you may still give you some reasonable estimate of the number to treat. I think the number to treat is very important concept, as you have said.
Right. Everybody needs to go to work.
Yeah.
You
I think it is very stimulating because we often extrapolate data from trials. So they're good trials, they come, and then sometimes we pick on some of them, apply to differently, and we need to know the flow of how it's done. And particularly sometimes when we take on some subgroup analysis that really worry me sometimes, we put it subgroup analysis and apply it to, yeah.
Hi, Key. There's a question from Dr. Javed Trivedi. It says, is there a caution to be excised when using local audit data, the fallacy of self-fulfilling prophecy?
Yes, this is a good question.
I might just put it on, I think he sent it to me, so I might just put it on.
I didn't see that in my chat
Yes,
box.
I'm going to share it.
Yeah.
Yeah, it's there.
But using local audit data.
I'm not sure I fully understand. I mean, assuming that these are correctly ascertained numbers, say for, you know, mortality risk in extremely preterm babies or BPD or severe ROP or NEC or whatever you can, as long as these data are accurately ascertained, I mean, you need to know anyway what your risks are and how they compare, and you do it in your within your network anyway, and you benchmark. I don't see where the self-fulfilling prophecy piece comes in, because I was just talking about, you know, how you decide how much bang for the buck literally you will get by applying a treatment that had a certain effect in a trial, but the baseline risk of those trial patients was different from yours. And so you cannot automatically apply it. So you have to recompute in order to get a sense of what it might do. And of course, this is important for any treatment, because particularly drugs like hydrocortisone, for example, are not trivial drugs. But it's particularly important in a situation where you already know that you have both benefit and harm. So
maybe, yeah, exactly. I think the Javid is asking a question. I think is sometimes, Javid, are you there?
Yes, I'm here. Okay.
Yeah, can speak.
Clarify, and what I meant was not in particularly referring to the examples that Barbara gave us this morning on caffeine or hydrocortisone or vitamin A necessarily, or BPT necessarily, but looking at other interventions and other bases of evidence where you might come across a paper which says, well, active intervention for a group of patients and makes a difference in the mortality in the long-term outcomes. And then you look at your own unit data and say, well, our mortality rate is so high, we can't really translate this action into our unit. But your mortality rate may be high just because of the unit practice of not offering care at all to the patient. And sometimes becomes a self-fulfilling prophecy for the unit that more you keep on doing more of the same because you do not have good outcomes. Taking the same data to fulfill your initial determination. And how does evidence-based relate to breaking that cycle?
Yeah, I think I begin to understand where you're taking this. But the first, in terms of applying the NNT, the first thing to say is that if your rate for something, let's say mortality, because you used that example, is very high, that automatically means that, and it's therefore likely higher than it was in the trial, then that automatically means that your NNT will be lower than in the trial. So there would be an incentive to try that. Or for example, I use another example of a trial that I did with folks in Australia again, a long time ago, prophylactic indomethacin. Yes, it reduces severe IVH by about a third. It doesn't completely prevent it, of course. So, and it is a powerful drug and it has some side effects. So if you have a very low severe IVH rate, you may think twice about using it. If you have a very high rate, I've never said you shouldn't be using it, although you may ask yourselves, why is the rate so high? Because there are many other reasons for why it should be high. So I totally agree with you, Javid. High rates of something should always be causing some soul searching, right?
May I
And not
also add?
complacency.
That's great. Thank you.
Yeah, maybe I add on to that because I do a lot of monitoring. Sometimes the most important factor is how confident is your rate. That is one of the difficulty when you have a small sample size and it fluctuates from time to time. We really do not know whether that is a chance observation that we be. And so you might be using thinking the rate is high, but in fact, it's just because of the variation of patients who are admitted at that time. That is important to realize that. So in fact, in our network, we do a lot of modeling to give you some of the results that you may help you to make some decision whether it's truly getting worse or getting better. Yeah, I think
that applies especially to long-term follow-up because event rates, for example, for CP or something or hearing loss are so low that obviously single center data become a bit iffy. I agree with you on that. And so you have to,
Yeah, thanks for that excellent question, Javi. Any other questions? Yeah.
There's another question, Key, from Dr. Talat, who says, how can we explain to parents if we choose one outcome over another?
I don't know. Don't know how you explain that to parents. And to be honest, I'm not any longer talking to parents because for the past 3 years, I've actually retired from clinical service. So I have not, talked to them about would they choose severe retinopathy or mortality. And obviously you wouldn't be doing that with a patient who's got the current patient in a child in the unit. I couldn't foresee that. But before you make something a unit policy, you may have maybe some deliberations that include parents of past preterm babies. The way people now have parents participate in research projects and designing research protocols. I think we have to begin to think about having parent representatives, not stressed out parents of actual patients in the unit, but be part of some of those decisions. not for each and every one, but for the ones that have the most implication. Because we don't know how people trade.
this
these,
is very
these
hard.
things off. Yeah, we don't know how people trade, and we make the decision for them, right?
Yeah, we recently did a survey on parents and to how they see based on their risk, so-called what they are acceptable to them or not, on mortality and major morbidity. That's if we start, there's a huge variation between parents.
Right,
And
I'm sure there are
yeah,
cultural differences, all sorts of things play into it. And of course, it's also always how it's presented, how well they understand the implications of each outcome. Yeah, I'm not for a moment saying it's easy. All I want is to move away from this simple prescription because we saw a 2.5% reduction in, or 2.8% reduction in mortality. You know, this is what everybody has to do.
oh, so that's fantastic. I think if they have no further question, we have to thank Barbara for a wonderful talk. And I think the message is very clear.
Thank you for having me back. And Julie, hopefully you take good care of your eyes.
I'll be very, very well behaved because the eye doctor will tell my mother.
Thank you, Ki. And thank you, Rahul.
Thank you. Thank you.
Yeah. Okay, thank you, everybody.
Stay safe.
And
Stay safe,
Okay.
Barbara.
Okay, bye-bye.